All right. Welcome to our 13th Medical Association Facebook Live. My name is Aruna Arora. I'm the current president, and I'm here today with our State Health Officer, Dr. Scott Harris, and Dr. Jeanne Marrazzo, the head of UAB HearSync Infectious Disease, and no stranger to any of us who watch the news. So welcome to all of you. Dr. Harris, do you want to go ahead and start with the update?
Sure, I'll be glad to do that. Thanks very much for hosting us again. We're really excited to have Dr. Marrazzo here. I'm very much looking forward to hearing from her myself today. Before we talk about COVID, it's just a good time to remember that flu season is here as well. We are beginning to see an uptick in flu cases in the state after really not experiencing much of a flu season last year when people were doing such a great job with mask and distancing and so many other things. We would encourage people who are watching today to please remember to get your influenza vaccine as soon as possible if you've not already done it. It is not too late to get it. You should go get it as soon as possible. We always want to remind people that it's perfectly okay to get your flu vaccine and your COVID vaccine at the same time. You don't have to wait between those shots. You can get them at the same time as well. So flu is starting to increase. We've particularly seen that kind of in the west central part of our state. The city of Tuscaloosa, in particular, the county of Tuscaloosa, has reported some increased numbers as well. So it looks like this will be just perhaps a regular flu season, and that's not a good thing. After having somewhat of a break this past year, we are seeing those numbers go up. So just be aware of that. In terms of COVID, we are in a somewhat better place right now than we've been really for quite a long time. We are pleased that our daily case numbers are down 2 or 3 or sometimes 400 cases a day. That's still way too many, but much better than we have seen. Our total number of people who are hospitalized around the state has improved as well. And on some days we've been below 300 inpatients. That's almost as good as we've been in a year or more. So we're very excited about that. However, at the same time, we still have some concerns as the holidays are rolling in. We know we'll have lots of people getting together. We still have about 2.5 million people in our state who are not vaccinated. We have about 2.1, almost 2.2 million who are vaccinated, but in about 2.6 who've received at least one shot. Those are better numbers, but we still have a lot of people who are susceptible. So just as a reminder, if you are someone particularly who's at high risk because of your age or because you have chronic health problems, please think about the things you can do, practically speaking, this holiday season. Remember, being outdoors is safer than being indoors if that's an option. Wearing a mask is definitely safer than not wearing a mask if you have the opportunity to do that. Mixing with people whose vaccination status you don't know, or if people you know are not vaccinated, is certainly going to be more risk than being around people who are fully vaccinated. And of course, being fully vaccinated yourself is the most important thing you can do. So please try to keep those things in mind. We want people to have a really good and enjoyable holiday season. The reason we've been working so hard to get people vaccinated and to beat COVID is so that we all can get back to normal and do the things that we enjoy doing with our friends and family. And we want everybody listening to do their part as well. So that's all I had, Dr. Arora. Be happy to answer any questions or anything else. Thank you.
Thank you. Thank you very much. So Dr. Marrazzo, I will let you kind of speak. I know you have some slides to possibly share to kind of talk a little bit about long COVID, and we can certainly let you share what you have, and then we'll kind of go from there.
Of course, I was muted. Let me just fix this so that I can share it, and then I will open it up. I've only got just a few slides, and I want to just sort of describe a little bit of what we are calling long COVID. What is it? How it looks like I can't share. If somebody could let me share, that would be great. It looks like host disabled screen sharing. But just to start, what I'll show you is a nice graphic that describes the main areas of the body that are affected by what we're calling long COVID. So we'll talk about that. We'll describe what it is. And then a JAMA paper, a Journal of American Medicine paper that came out, thank you, that worked, just a couple of weeks ago that shows you should be able to see that now, right?
Yes.
Great. That talks about how common this is. So first of all, let me describe why this even became a thing. It became pretty clear after the first wave, really. So last spring, starting in the Northeast and in Europe, that there was a significant subset of people who really took a long time to get better from COVID, didn't get better, or got better, but then had relapses of some very distinct symptom complexes. So that's when people sort of got interested in this concept of long COVID. And since that time, there have actually been a number of studies looking prospectively and retrospectively based on people reporting having COVID or being documented as having COVID on what exactly this was about. And in fact, you may have seen about 2 months ago, the National Institutes of Health announced that they were funding a very large, over $400 million study to try to figure out what was going on with this syndrome. They call it post-acute SARS-CoV-2 syndrome. So it's called PASC, or PASC. The program that they are funding is called the Recover program. And I'll come back to talk about that at the end. So what this is that you essentially can see a completely diverse set of symptom complexes, whether you were severely ill enough to be hospitalized or whether you were simply sick enough to be ill at home as an outpatient. There are fewer studies in the last group, and this is a nice paper from the British Medical Journal, which is continuing to update its systematic review. And on the right side of the slide here, you're seeing a summary of what the symptom complexes have been described as being in a relatively small number of studies in people who were not hospitalized. So only 4 studies, and you'll see there are 26 studies from hospitalized people, and that's not surprising, right? It's easier to enroll patients from the hospital and follow them up, et cetera, or to contact them after they've been hospitalized. So when you look at these studies with about 1,200 people, and these are international studies, there are probably more in Europe right now than in the US, just because Europe experienced, of course, earlier waves than we did, although we are catching up. This is what you are seeing, and the size of these circles is an estimate of how commonly these things are seen. I'm going to show you some graphs in a minute that get to some specific percentages that I think are helpful. But when you look at it, it sort of falls out into several areas, and these are probably not surprising to anybody who has had COVID or who has really felt sick for a long time after having a viral illness, right? What viruses do we think typically is associated with these things? Mono, often associated with a chronic fatigue sort of syndrome. People who have had cytomegalovirus or CMV, but there are lots of infections that people have associated with a chronic fatigue-like syndrome that I think is a very real illness, and a lot of people have been very interested in trying to figure this out. So what do these folks get? Well, probably the most common things are systemic. And you can see in the blue here, that includes fatigue, weakness, fever, sweats, night sweats, sometimes lymph nodes and dizziness. But I would say that weakness and fatigue are probably the biggest systemic things. And then the other area is neurocognitive impairment. So there is this COVID brain fog that people describe. And I actually have talked to several people in the last several months who really feel like their concentration is significantly impaired, their memory is impaired. They just don't feel like themselves. They don't feel as fast. And that's a very interesting, unfortunate event. The other thing that I would say comes next is psychosocial and social, right? So anxiety and insomnia are really quite predominant. So sleep disorders, anxiety, and just basically feeling like something is not right. Sounds kind of vague, but it's been consistently reported. And then less common, but actually quite bothersome, are these cardiopulmonary manifestations. And so one of the things that people talk about a lot is this postural orthostatic hypotension, or POTS syndrome, postural orthostatic tachycardia syndrome. And what that means is that when you stand up, when you move around, particularly when you stand up from lying, you get lightheaded, your heart rate goes up, you feel palpitations, and actually you can measure blood pressure going down. So it seems to be a dysregulation of the autonomic nervous system that has been seen with this. And people are very symptomatic. That's probably the most common cardiopulmonary thing that we see. A lot of people continue to describe cough. So they really just don't feel like they're breathing, or their breathlessness is still present from the illness. They just don't feel like they can get back to as deep a breath. A lot of people these are often young people who often were unvaccinated, and they were very, very functional, often athletes previous to this, and they don't feel like they've been able to run, for example, what they used to run. So I would say that's a big one. And then the other big one to think about is neurological and neuromuscular, probably decreased sense of taste and smell. That has, we know, presented a lot with acute COVID, right? But with long COVID, we have seen it persist for months with people, and that is clearly not a very positive thing. You know, at its worst, people have described walking or gait abnormalities, clumsiness, sometimes headaches, and that sort of thing. But really, when you look at this list, you can pretty much find almost anything, any organ affected. And it just reminds you of what it feels like to have a disseminated viral illness, right? It's like how you felt when you have flu or COVID. It just does not feel very good. And then what about people who were more severely ill enough to be hospitalized? You can see that the bubbles here are bigger. That means that they are very common in people who leave the hospital. And again, I'll show you some numbers in the next couple of slides. They really follow the same pattern, right? So it's probably more systemic illness, probably more anxiety, which makes total sense if you've been hospitalized for COVID. Not a particularly pleasant event, I would imagine, in most people's lives. Maybe a little less of the neurological, and then skin rash and hair loss. There has been hair loss associated with post-COVID, which is interesting. I have no idea what that's about. So again, and gastrointestinal complaints too are more common in people who have been in the hospital with COVID than not. And that can include all of the sorts of things that people find when they get GI upset, nausea, vomiting, loss of appetite, diarrhea, stomach pain. So again, a really wide array of things. What I would say about these is that most of them are pretty nonspecific. The only ones that I think are really very notable in terms of COVID or SARS-CoV-2 are the association with loss of smell or taste, which we know is an unusual manifestation for a virus. We've never had a virus that went through our community that caused that particular kind of thing. And then this POTS syndrome, so the cardiovascular, autonomic, function abnormalities. Now I know these next three slides, I only want to show them to give you a sense of what's really coming out in the literature now that we're finally getting some good data. This is a great study that is a systematic review in JAMA that was published just last month. And what I want to show you is that they did a very, very deep dive, looked at a lot of data from a lot of studies, including all of these countries. So it's actually been very good. They divided up the definition of post-acute SARS-CoV-2 syndrome by clinical syndrome by the short term, the intermediate term, and then the long term. So the short term is the first couple of months after being sick with COVID. I think it's actually 60 days here. The intermediate term is out to about 150 days. And then the long term is out up to 250. So you're getting into the 6-month kind of period. And these are the countries for which they had data for each of these areas. So not surprisingly, the countries that they have data on long-term COVID sequelae are the people or the countries that had the earliest waves, right? So Italy, China, Norway, et cetera, and the US. So how many people actually described post-COVID syndromes, like the ones that I just mentioned in these studies? It's a lot. Overall, here's this frequency of past symptoms. It's over 50%. And that's consistent across countries, across a lot of things. So I actually think that this, and it didn't really go down over time. So 50% of people experienced lingering symptoms in the short term, 50% in the intermediate term, with a lot of variation, of course, and then actually about 50% in the long term. So this is another reason that I try to tell people that, you know, getting COVID is not fun, but having long COVID is even less fun. They actually went into nice detail about the frequency of each of these types of illness in the long term. So remember, the long term is in the blue here. And they looked at what the frequency of cardiac, digestive, skin, ENT disorder was, and I'll show you on the next page a few more things. So the frequency of palpitations and chest pain, about 1 in 10 to 1 in 5 people. And again, this is up to 250 days out. So this isn't like a long time out. You should not at this point have virus at least actively replicating in your body. Digestive disorders, any about 15%. Most of that was decreased appetite, but some of it was abdominal pain, diarrhea, and vomiting. And then skin disorders, again, hair loss in almost 20%. So that's very interesting. I don't know anyone who knows what the mechanism of that is, but it's not a good thing if you don't really want to lose your hair, which most people don't. And then sore throat for ENT disorders, uncommon, but described in a small number of people. And then the last slide, sorry it's so small, but I will try to point out the main parts of it that I think are interesting. How many people had a headache? About 10%. But almost 15% had a taste disorder and slightly more had a smell disorder at this late stage. Cognitive impairment, about the same, but a nice wide range. Memory deficits and difficulty concentrating. So you can see that gradient of what people are experiencing. Generalized anxiety disorder in 30% of people. Now, hard to know what that is related to. Is it because these people were, you know, on the verge of getting intubated in some cases, or they were around people who were really sick? Who knows? I mean, it's a pretty anxiety-producing situation, and indeed, everybody was pretty anxious, I would say, during the height of COVID. For respiratory disorders, you can see that for dyspnea or shortness of breath, it was about 25%. And if you look at chest imaging, that's actually even more common. We know that people have residual chest X-ray and mostly chest CT abnormalities for a while after COVID. And a lot of people required ongoing oxygen use. And then mental health disorders, talked about generalized anxiety, mobility impairment, functional impairment was really common, meaning basically that they just didn't feel like they could do what they used to do. And that was associated with fatigue or muscle weakness. So I think that these data are concerning. They really say that we are dealing with a real syndrome, that these patients are suffering. They're suffering from something we don't really understand. And that's why the NIH has funded the RECOVER study. And I'm really happy to say that UAB was awarded a grant to participate in the RECOVER study. And we were awarded that grant with our partners at Louisiana State University and Alabama State University, or University of Southern Alabama, sorry, USA. And we are going to be enrolling about 900 or so people from those 3 sites, starting, we hope, next month. We don't have everything quite ready yet, but we are very interested in enrolling people, ideally with recent COVID or current COVID, because we want to follow people for up to 4 years to really get a sense of what is going on here. We'll kind of do an initial assessment of a lot of people, and then a subset will be taken in or invited to be in a more intensive assessment of cardiac, neurologic, in particular, and pulmonary function. So keep your ears and eyes open for that. We will be letting everybody know, and we will definitely communicate with Dr. Harris and Dr. Arora to let them know when the study actually opens up. And we're pretty excited about it because we really hope that we can help people figure out what the heck has been going on. So just to say thank you. And I'll stop there and hope we can have a discussion and maybe answer some questions. Although honestly, I wish I could tell you more than I just told you. So I'll stop.
Those slides were really useful.
Thanks.
Yeah, I think, you know, as we kind of talked about before we went live, you know, everyone immediately goes to the hospitalized and the severely ill. But then once those patients, and even the patients who just had mild COVID, once those patients are then suffering with some long COVID symptoms, you know, the PASC, it's almost like you have this invisible suffering because these patients no longer, you know, they don't express that their life has been so altered, and they try to put that face forward that, you know, I'm grateful that I am doing as well as I am, but internally they struggle with everything you described. I mean, the insomnia, the anxiety, the palpitations, you know, the exercise intolerance in many young people who are used to jogging and running for stress relief can't immediately turn to that. So it really impacts. And we didn't discuss, I don't know, I know kids. So kids and long COVID.
Yeah, that's a great question. I wanted to address that, and also vaccinated people.
Yeah.
So does vaccination prevent long COVID? I don't know the data for kids. I looked and I couldn't really find anything. So I'm sure there are data out there. I just don't, I'm not aware, but we can take a look in a moment and see if there's something new, but I haven't seen anything. I did want to mention that vaccination doesn't appear to prevent long COVID if you get infected as a breakthrough infection. So there's one study, there was a paper in the New England Journal that looked at breakthrough infections in the last month or so. And I think the people who had breakthrough infections, something like 20% experienced long-term symptoms consistent with long COVID. You know, whether that's a similar number to what you're seeing in that JAMA paper, which was 50%, maybe it's lower if you're vaccinated. I don't think we know because we don't have the cohort studies to directly compare. But the point should be that if you're vaccinated and you get COVID, it doesn't mean you're not going to get long COVID. You're not immediately protected.
Dr. Marrazzo, do you have any sense of how to predict who's going to be affected by PASC and who's not? Or are there differences between these groups?
I do not know. I do not know. I wish that I could. And I am just to let you know that there is a small, I'm just looking this up just in answer to Aruna's question, that there is not a lot of data on children, but it has been reported. So like 5 weeks after their initial infection in the UK, 15% of kids had symptoms. So I think it's probably out there. One can only hope it's not as common as it is in those adult studies.
Right. So back to the vaccinations, like if you choose not to get vaccinated versus getting vaccinated, some of the risk that gets cut down with long haul COVID in those two groups, can we talk about that?
I'd like to say it's cut down, but
Yeah.
by maybe 50%, right? If you
Right.
believe the JAMA paper is mostly unvaccinated people,
Right.
but they didn't look at that. So they weren't able to look at that. So that is around 50%. And then if you look at that New England Journal paper, which wasn't designed to study long COVID, they just threw it in there as I think they had looked at that group. It was around 20%. So, I mean, maybe breakthrough, you would think it might help. You know, I think anything that reduces your risk of severe disease, because, you know, if you look at the comparison that I showed first from the British Medical Journal article, the likelihood, it appears that more severe COVID is associated with a higher frequency of post of long COVID on all those, because all those circles were bigger, right?
Right.
Now, could there be some bias there? Maybe people who are in hospital are more deconditioned, more likely to have had hospital associated complications, all that stuff.
Mm.
So I'm not 100% sure, but my guess is that more severe COVID would be associated with a higher likelihood just because it's such a hit on your body. And maybe there's more immune inflammatory stuff going on there than would be the case with less severe disease. So I think we can't say for sure yet, but some reasonable hypotheses to help people.
Yeah. In terms of patients that have sought out care, in your clinics, the average number of months that they struggle.
Yeah, I would say people, like you said, try not to make a big deal out of it because
Yeah,
a lot of them have to go back to work, right? People have
right.
been out of work. I mean, they can't, and then a lot of them, it's admitting a bit of a disability, and that has implications. They don't want to go in there. I talked with somebody yesterday who didn't want to put it in their medical record because they were very concerned about the implications for insurance and all that sort of stuff. So the people that we have seen have generally been 3 months and later, I would say. Yeah.
Yeah.
The thing I think that this paper and other people have really emphasized is the value, and this is why I worry about places where access to healthcare is not great. I mean, you need an interdisciplinary clinic. Like, you need to have the cardiology person available. Maybe you need a neurologist available. You may need a pulmonary person available. I mean, and we can't even, get primary care docs available to see a lot of these folks. So when the experts say, you should have a multidisciplinary program to take care of this stuff, it's much easier said than done. Which is why I think, having this grant for us is going to be very helpful, and having clinic as a referral basis would also be very helpful.
I think you hit on a really great point because, sometimes they may see one specialty, but then, the multidisciplinary, in our ALS world, the multidisciplinary clinic certainly makes all the world of a difference to a patient. And so this, ability to actually treat their symptoms and let them actually go see clinicians and not feel like it's such an obstacle. And maybe some answers are out there for them and not feel so overwhelmed in despair.
Yeah, I agree. And the other thing is that, sometimes I think if you're not really necessarily like used to prescribing short-term antidepressants or something like that, or even an activating kind of drug for serious lethargy or ADHD sort of stuff, you might not do it. But if you're in a place that's really dedicated to helping people function better as part of this complex of illness, then that might help people get the help that they need.
That's a really good point. And get the actual screening tools. Sometimes the screening tools don't get implemented.
Exactly. Exactly.
Yeah. Dr. Harris, do you have something to add here?
I actually was just curious to know, Dr. Marrazzo, do we know anything about any specific therapeutics or any specific treatments? Obviously, I guess there are a lot of illnesses that, like you described earlier, where people may have sort of post-acute symptoms that can go for weeks or months, and we kind of treat those people symptomatically. But anything on the horizon maybe that would work for this illness directly? Or
I wish that there was, but right now it's really individualized kind of symptom and complex based management. So again, for psychologic issues, for mental health issues, for that sort of stuff, hydration. If you've got the POT syndrome, make sure that you're not, that for orthostatic hypotension, you want to make sure people are hydrated, help people sleep. So, you may even use a short-term sleep medication to help people get a good night's rest, because of course so really it's fatigue management strategies that are not very sexy and not very medicalized, but I think are really great. If you have pulmonary or cardiopulmonary pathology, some people are using pulmonary rehab or cardiac rehab, which I think is a great idea. Physical therapy, physiatry, if you've got muscle stuff. So it's all very It's all very, very, very symptom based. So I think that's the key thing. One question I have is that we're really interested in looking at in the RECOVER study is with the availability of the new antivirals. So now we have the Pfizer drug that has been submitted to the FDA for emergency use authorization, which is an antiviral drug that has to be given within 5 days of getting COVID, and you take it for, I think, 5 days as well. We haven't seen the data, but Pfizer says that it reduced severe illness by 89% in hospitalization. So, and then a Merck drug, which did the same thing by about 50%. If you get those and you treat your COVID early with oral antivirals like Tamiflu for influenza, might you alter the course of future COVID? Because those will shut down viral replication, right? So I think it'll be very interesting to try to get people in studies now before those drugs are widely available and look at the development of post-COVID with those drugs. Lots of reasons to get those drugs to people, make them feel better, prevent hospitalization, maybe even reduce transmission, although we don't know that will happen. But maybe there's a chance that they will affect the likelihood of long COVID. That would be fantastic.
Yeah,
But
that
we
is
don't know that yet.
I appreciate you drawing attention to this, but one of the big arguments we have to hear from people all the time who are young, healthy adults, or even people talking about their kids, is that they don't feel that they are individually at risk for serious illness. And so that's a problem with honestly everything we try to do in public health, whether we're talking about non-pharmaceutical interventions or whether we're talking about vaccinations or so on. But clearly there's a lot more at risk than just what happens during the acute illness itself. And so this is actually a great conversation, and one that we really need to continue to highlight for people.
Yeah, it is. And it's come up a lot, Scott, when people have talked about the myocarditis risk, right, with vaccination in young men in particular. And there are several nice kind of teaching tools that emphasize that the likelihood of you having cardiac complications if you're a 25-year-old man is much higher if you get COVID than if you get the vaccine, right? I mean, the vaccine is associated with an increased risk, but you would rather get the vaccine and have a little bit of that than you would to get COVID. And I think, I think you're right. People just shrug it off and don't realize it. So it's a weird virus and we don't understand it. And so it's like, I don't think it's just a cold virus. We know that it's not just like the flu, which is not good either, but I think it's not a good virus to get and to have in your system.
Yeah, for sure. I think that raising some awareness to these long COVID symptoms, hopefully will, we have so many people in our state who are hesitant to get their first vaccine and, worried about the side effects of the vaccines. But, based on the slides that you showed, I mean, it's extensive what COVID can do and the symptoms that you can end up having, not just in the immediate illness, but afterwards. So I think that you're right. I mean, just the fact that is raising awareness to something that people don't think about, long COVID.
Yeah, and even for primary care providers too, recognizing that there are, and I believe I don't know if it was you, Scott, or Aruna who mentioned this, but there are tools you can use for people. I mean, there are sort of, PTSD scores, there are questionnaires about depression that are actually pretty helpful, and they can at least give you some objective things to follow and make you feel like you're getting some data and make the patient feel like they are actually being taken seriously, which I think is half the battle here. So that can be very helpful.
Any closing comments other than get vaccinated?
Let me
Don't
say
forget
that,
mitigative measures during Thanksgiving.
I'm sorry, I can't miss an opportunity to put in a commercial for that. Vaccination remains the most important tool we have to prevent this illness, and I just can't emphasize that enough. When we had a real surge in the end of July, August, and September with the Delta variant, when hospital numbers were so high, when deaths were dozens of people per day, a lot of people got motivated to go get vaccinated, and we gave a lot of first shots then. That's unfortunate that it took that And yet at the same time, it's a little bit encouraging because it makes me feel like that a number of the people out there who haven't chosen to get vaccinated maybe aren't hard-nosed. They're just people that haven't been sufficiently motivated yet, or just haven't decided to act yet. But as numbers have gotten better, we're thankful for that, and yet we've seen new vaccinations fall off as well. And in fact, most of the shots that we're giving right now are third shots. They're booster doses or they're additional doses for immunocompromised people who are getting the third shot. We're not seeing much in the way now of primary vaccination series. So again, we just want to remind people how important it is. Thanksgiving's coming up in a week. You can't, if you haven't been vaccinated yet, you're not going to be protected by Thanksgiving. There is still time to protect yourself for the December holidays and the new year. You do have time to protect yourself and to protect others. We have vaccines that are free and widely available. They're in multiple places in all parts of the state, in every county, almost without exception, without appointment even being needed. So please take advantage of that opportunity.
Yeah, and I will just add to that. Can't emphasize that enough. But also, I feel like I'm always the prophet of doom in these things. But I don't really like what's happening in Europe right now. What's a lot, even or Minnesota for that example, for that matter, Michigan, Vermont. So places that have high vaccination rates are having high rates of breakthrough infection. Right. They're not, hospital systems are generally not being overwhelmed, but we don't want to test that here. And especially with our high rate of unvaccinated folks. So really, I think the best thing we can do for each other and for ourselves is to go ahead and get vaccinated before the holidays for sure. So I totally agree. And I thank both of you for really being so incredible out there. You've been amazing warriors in this space. So thank you very much for continuing to deal with it.
Thank you. We're ever so grateful for you. And I appreciate you raising awareness that there are infections happening. Even if we may be low here, it's always important to look to people like you and Scott, who are following the trends, and remember that that could very well be us. And we are more of a target because we're lowly vaccinated here. So,
right.
And, it's a trickle effect in the healthcare system, because when you get your hospital's full again, all of the elective procedures that are not elective procedures can't happen the way they need to.
Oh yeah.
And it's just, if we actually look back on this period of time, I'm afraid we're gonna see the late cancer diagnoses and the late surgery. There's the implications health-wise are far grander than just our COVID situation.
Yeah, I've been calling those shadow pandemics. I think that, we have seen cases, there is no question. We saw people who were scheduled for a follow-up CAT scan last March and who just couldn't get in, couldn't come back, things shut down, came back in September and had cancer. That may have been caught. And so I have no doubt that's going to happen. The other thing is the opioid epidemic, right? I don't know if you saw today, but we have now exceeded some incredible number of deaths. I'm sure that was worse because of all the social isolation and loss and everything. So so we don't want to go back there.
Yeah, shadow epidemics. That's exactly right. It's all stuff associated with this.
Yeah. So keep up the good work.
Well, you too. I always look forward to seeing you on the news, and I'm glad you changed your glasses. Thank you.
I'm a victim of my own
glasses.
All right. Well, it's great to see you
Dr.
both.
Marrazzo.
Hope to see you in person soon. Okay.
Sounds great.
Bye.
Thanks, everybody.
Thank you.